West Zone. And this is now we have planned a series of webinars where we want to, with the aim of helping our postgraduates who are spread across all various institutes to have a uniform teaching platform and cover topics and the basic exam oriented topics. So we, Dr. Sable, the first webinar along with help of Dr. Subodh Shivre, and we are very thankful to both of them for taking this initiative. And the first would be, of course, on prostate, as you all know, which is one of the most important topics of urology. And the whole webinar is aimed with the aim of helping the postgraduates and the young urologists who are either appearing for their exams or are all set to launch into their practice. So thank you, Dr. Sable. Thank you, Dr. Shivre, for taking this initiative. And I would like our president, Dr. Ashish Patil, to please speak a few words before we hand it over to the conveners for today's meeting. And also, I would like all the postgraduates to let us know their feedbacks and how we can further improve with these programs for subsequent webinars on different topics. And any topic which is of interest to all of you and you desire to be covered, please do let us know. You can mail me directly or WhatsApp me directly. Over to you, President Sir, Dr. Ashish Patil.
Thank you, Secretary Sir, Dr. Rajesh. I would like to welcome all the PG students, the whole council, and all the attending delegates to this innovative program, which has been specially designed for the postgraduates. I think it is a good initiative when we thought of it. So me and the whole council have sat together and we have really tried to craft out a good program for all of you. The council has been very proactive, and I thank the council especially for making this initiative possible. I would like to thank all the PG students who are joining us today, and especially the faculty and the conveners who themselves are masters and experts in the field. As Dr. Rajesh said, this is one of the first of the webinars, and I congratulate the eminent faculty and thank them all to have given their precious and valuable time for this initiative for the postgraduates. With regards to all our teachers who have mentored us throughout all these years, I declare this PG program open. Over to you, Rajesh. Thank you so much.
Thank you, Ashish. Thank you very much. And once again, I would like to thank the conveners and thank you all the faculty members for taking out time from their busy schedule for the aim of helping our postgraduates. Thank you very much, all of you. And over to Dr. Sable and Dr. Subodh Shivre to carry on the webinar.
Thank you very much, Rajesh sir, Ashish sir. Thank you.
Thank you, President Dr. Ashish, Secretary Dr. Rajesh, for giving us opportunity to kickstart the academic activity of current USI office bearer, West Zone office bearers. This is the first of its kind, but these activities, as the President said, these activities, academic activities, will go on all throughout our tenure. I thank Dr. Subodh to take up a responsibility for a convener for this today's activity on benign prostatic hypertrophy. And because it is intended for residents, younger generation consultants, we have tried to include the residents also, at least on the basic sides of the subject, which will definitely help everyone to revise, and it will boost most of the residents to keep studying on these lines so that they'll be prepared for these topics. And this, as Dr. Abhijit Patil, council member, had told, these recordings will remain on West Zone YouTube channel permanently, so they can refer to that. I thank our expert panelists, Dr. Ravindra Sabnis and Dr. Kirpekar sir. Unfortunately, Kirpekar sir was to speak on open prostate, but he could not prepare because he was out of town. But he is joining, and he has just returned to Pune. He's joining as an expert panel today.
He's already joined, Vilas.
Yeah,
he's already he's already there.
Yeah. Yes. So now I'll request our first speaker, Dr. Radhika Salpekar, who's a second-year urology resident at DY Patil Medical College. And she's going to talk on embryology, anatomy, and applied anatomy of the prostate. Over to Radhika.
Thank you, sir. A very good evening to everyone present. I'll just share my screen now. So are my slides visible?
Yes, yes, they are visible. Yes, they are visible, Radhika. Go ahead.
Okay. So very good evening to everyone who's joined us online. I am Dr. Radhika Salpekar. I'm a second-year resident from Dr. D.Y. Patil Medical College, Pune. Just to kick off our two-part webinar on navigating the benign enlargement of prostate, I'll be discussing on a topic that is very basic and it is well known to all of us. However, it forms the core basis of any surgery on the prostate. So let's begin our discussion on the anatomy of prostate. Just to have an overview of what we'll be discussing today, we'll go over the embryology, the gross anatomy, the presenting parts of the gland, its coverings, the lobes and zones, the transrectal ultrasound anatomy, the venous and arterial anatomy, and last but the most important, that is the pelvic plexus. So just to have a brief overview of the embryology, the prostate gland develops from the ventral urogenital sinus and its development is androgen dependent. So around the 10th week of gestational life, the prostate budding starts, which results in proliferation of the epithelial bud from the urogenital sinus. Around the 11th week, the 5 independent solid cords develop, acini and lumen, and around the 13th week, these acini develop their secretory activity. The surrounding mesenchyme also continues to develop muscle and stroma, and thus we have a developing prostate gland. So as we all know, the prostate is an inverted pyramidal fibromuscular gland with a predominantly glandular architecture and only around 30% of fibromuscular stroma. A mature gland weighs around 20 to 25 grams. The prostate lies in a lesser pelvis. It is in between the pubic symphysis and the rectal ampulla, and it extends from the bladder neck till the urogenital diaphragm. So we have the base of the prostate, which is a broad base, which is placed superiorly and attached to the bladder neck, and the prostatic urethra pierces through it. The apex, which lies inferiorly, is more tapering and it sits on the urogenital diaphragm. It is very closely related to the rhabdomyosphincter of the urethra. So the prostate has 4 surfaces, the anterior one, which separates it from the pubic symphysis, which is also known as the retropubic space of Retzius, and it is also connected to the pubic symphysis by a very important structure that is known as the puboprostatic ligament, which, as we'll see later, is pierced by the deep vein of the deep dorsal vein of penis. On the posterior side, the rectum is separated from the prostate by a thin, flimsy layer of connective tissue, which is known as the Denonville's fascia, and on both inferolateral surfaces, we have the levator fascia. Coming to an important topic of the coverings of the prostate. So the prostate and the bladder are both covered by a multi-layer of connective tissue, which is known as the endopelvic fascia. And the part that covers the prostate all around is known as the prostatic fascia. The part that overlies the levator ani muscle here is known as the levator fascia or the pelvic fascia or the lateral pelvic fascia. And posteriorly, we have the Denonville's fascia, which, as we discussed, it has 2 laminae, the anterior one and the posterior one, which on microscopy we cannot discern. The important thing about Denonville's fascia is that it forms an important oncologic barrier between the rectum and the prostate, and it is also known as a barrier between the wind and water. So a triangular space is basically formed between these 3 fascias here, where the neurovascular bundle of Walsh lies. So just an important point in this slide is that the neurovascular bundle of Walsh lies outside of the prostatic fascia and in between these 2 layers. So the prostatic capsule is nothing but a condensation of the peripheral part of the gland, and it forms the surgical plane of cleavage for all our surgeries. Now let's discuss the anatomical lobes of the prostate. We have 5 of those. The first one is the anterior lobe, which is basically stromal. It doesn't have any glandular tissue. And on the posterior side, we have the posterior lobe, which is a predominant site and notorious for carcinoma. Next comes the median lobe, which is wedged between the ejaculatory duct and the urethra and has abundant glandular tissue and hence is notorious for benign enlargement of prostate. And on the 2 lateral sides, we have the lateral lobes, which are seen on cystoscopy. Next, we'll discuss about the McNeil zonal anatomy, which is the pathological zonal anatomy. So wrapping around the pre-prostatic urethra, we have the transitional zone. Takes part in the benign management of prostate. Then comes is the central zone, which is hugging the ejaculatory ducts, behind which lies the peripheral zone, where most of the chronic prostatitis and adenocarcinomas take place. And anterior to that, we have the anterior fibromuscular stroma. So this slide is generally is basically a recap of what we just discussed. An important thing to note is that on digital rectal examination, what we palpate is essentially the peripheral zone. So now let's come to the transrectal ultrasound of the prostate, which all urologists do quite commonly on the OPD basis. It is done essentially to have a prostate volume estimation as well as to take transrectal biopsy for prostate. Something to have in your mind is that on ultrasound, the transitional zone here, it appears more heterogeneous when compared to the peripheral zone, which appears a little more homogeneous. So any hypoechoic lesion, if we see, we can have a suspicion of a malignancy. Next is the prostate volume estimation. These are the three commonly used formulas that we have. The only lacuna being that these formulas just assume that the gland conforms to an ideal geometric shape, which sometimes is not the case. So just to have a more accurate and a precise measurement or estimation of the volume, we can do a planimetry in which we have serial transverse images taken at 3 to 5 millimeter interval through the length of the gland, and then we can have a mapping of the surface. The next important topic we have to discuss is the venous drainage. The prostatic veins basically drain through something called as the Santorini's plexus. The deep dorsal vein of the leaves the penis under the buccal fascia between the corpora cavernosa. It penetrates the urogenital diaphragm and then the puboprostatic ligaments to lie over the vesicoprostatic junction. In this place, it divides into the superficial branch and the two right and left lateral venous plexuses. So these plexuses further go on to mix up with the pudendals, with the obturator and other pelvic venous plexuses to go on to form the inferior vesical vein, which drains into the internal iliac vein. Now, these veins are quite friable and they are quite notorious in causing bleeding in TURP as well as in open surgeries. So one must be very mindful when operating around these veins. The next is the arterial supply, which is via the inferior vesical artery, which is a branch of the internal iliac artery. So Flox in 1937 spoke about two branches of the prostatic vessel, first being the urethral group, second being the capsular group. So here in this diagram, the urethral group is the one that enters at the vesicoprostatic junction in the posterolateral side, goes on to supply the bladder neck here, and then supplies the periurethral part. It essentially travels from 1 to 5 o'clock and then 7 to 11 o'clock. And hence we have, all of us have encountered bleeding from the artery at 5 and 7 o'clock. The next is the capsular group of arteries, which again lie in the posterolateral area, but they supply the peripheral part of the gland. An important thing to note in this slide is that this capsular group of artery essentially lies in the lateral pelvic fascia and they travel along with the neurovascular bundle of Walsh. These capsular arteries act as a landmark, which is a macroscopic landmark to identify the microscopic venous plexuses. Now, talking about venous plexuses, this is an autonomic innervation to the pelvic organs. We have the parasympathetic and the sympathetic comes via the hypogastric nerve from the thoracolumbar outflow, and then the sympathetic is via the sacral S2 to S4. So in this diagram, I would just explain briefly about how the pelvic plexus is formed. It is basically a fenestrated rectangular plate that is around 5 to 11 centimeters from the anal verge. It is formed by the hypogastric nerve, which forms a sympathetic component, and the parasympathetic by S2, S4. This fenestrated rectangular plate goes on till the tip of the seminal vesicle, wherein after that, caudally it becomes a part of the capsule of the neurovascular bundle. So this is an important part to remember. It lies outside the prostatic fascia and between the prostatic and the lateral pelvic fascia. The last to be discussed is the lymphatic drainage, which is into the obturator and the internal iliac lymph nodes. Thank you.
Thank you, Radhika. Thank you for a nice presentation as well as keeping it to the time. I request the next speaker, Dr. Kavan Dakwani, who's Dr. Ayesha Saba. She is a resident at MGM College and Hospital, Aurangabad, that is Sambhajinagar. She is going to talk on pathology and pathophysiology of the prostate. Over to Saba. Can you share your screen?
Yes, sir, sure.
Aisha, if you're not able to share PowerPoint, share the whole screen.
Yes, sir, sharing.
We all should thank Dr. Abhijit Patil for technical support, and he is really doing good work for creating a new website for Wezone USI.
Aisha, if there is a problem, sir, can we proceed to the next speaker and maybe I will help her by that time, sir?
Yeah.
Yes, sir.
Subodh, we should move to the next speaker. Dr.
Yeah.
Kavan Takwani is
Is
a
he ready?
resident
Yeah.
at Muljibai Patel Nadiyar.
Sure.
He is going to talk on clinical features, presentations, and basic investigations for the benign prostatic enlargement.
Good evening all. I am sharing my screen.
I have to stop sharing.
Are my slides visible?
Even, yeah, slides are seen well. We can start.
Good evening all. I am Dr. Kavan Takwani, a second year trainee at MPOH Nadia, and I am presenting clinical features, presentation and symptom scorings of BPH. So evaluation of BPH mainly includes clinical history, which includes the understanding of the symptoms and its impact on the quality of the life of the patient. Then converting this history into the objective evaluation with the help of symptom questionnaires and bladder diaries. And then with the help of diagnosis, we can proceed further with the blood, urine, radiological and other investigations. So before proceeding, we have to understand the concept of the symptom complex of the BPH, which was initially given a name of prostatism in 1976. And currently the new term in ICS is the lower urinary tract disease symptoms. Basically, it is a group of symptoms associated with the bladder outlet obstruction due to the enlargement of the prostate. These symptoms are divided into three categories: the storage symptoms, voiding symptoms, and the post-void symptoms. Storage symptoms include frequency, which is more than 7 times daytime frequency, which is mainly assessed by the voiding diary. Then comes the urgency, which is sudden, unexpected, immediate, and compelling need to void. Then it is nocturia, which is the which patient has to wake at night to void, and it can be more than 1 times. Then comes incontinence, which is
Abhijit, sorry for interruption. There are plenty of comments that people are not able to view it properly. Abhijit, can we do something for that?
Sorry, sir.
There are plenty of viewers who are not able to view the things properly.
Okay. Let me see. I think it is seen properly, sir. Kavan, I think you continue. By that time, I'll sort it out.
Okay, sir. So the next symptom is incontinence, which is leak of the urine. It can be continuous, which is throughout the day and night, or it can be intermittent, which is in discrete amounts in the daytime, at the nighttime, or it can be combined. Then comes the voiding symptoms, which is hesitancy, which is difficulty in initiating the void. Then comes straining, which is need for intense effort, like Valsalva maneuver. Then weak stream, which can be observed or a recorded stream. Intermittency, which includes several discrete starts and stops during the voiding. And dysuria, which is burning or discomfort during the void. Next group is the post-void symptoms, which include sense of inadequate evacuation, where patient needs to go to the toilet immediately after the void, and post-void dribbling. Now, to convert these symptoms into objective evaluation, we need symptom questionnaires. And the importance is that the LUTS symptoms are very subjective, and making patient understand them in layman language is very important to really assess the impact on quality of life. And again, giving patient time to think while answering this question is also very important. And AUA both guidelines suggest that it has strong strength of evidence and recommendation to use these symptom questionnaires at the initial time of evaluation and in the progression and follow-up of the patients. The most commonly used symptom questionnaire is the International Prostate Symptom Score, IPSS, which is actually a modification of the AUA-SI score. It includes 7 questions, which includes the frequency, urgency, nocturia, intermittency, straining, then sense of inadequate evacuation in the post-wed symptoms. And the 8th question, which was added at the end, was the quality of life due to urinary symptom question. And many studies have been done which has shown the quality of life question to be the single best predictor of the treatment response. Every question is given score from 0 to 5, total score being 0 to 35 in that range. And the score is classified into, if it is 0 to 7, then it is mild. If 8 to 19, then it is moderate. And if it is 20 to 35, then it is severe. The limitations of this score is incontinence is not included in the IPSS, and the quality of life assessment is very limited. Then came the visual prostate symptom score by Vanderwelt in 2011, and they have given the pictorial representation of the IPSS questions, which include frequency in the day and night, force of the urinary stream, and feelings about the bladder symptoms. And these are mainly used in patients who have low level of education or who find it very difficult to understand the questions given in the IPSS form. Because if we try to interpret with the help of a nurse or even a medical practitioner, then some amount of bias will be there. Then comes the evaluation of incontinence, for which we use ICIQ AMLET score, which is basically created from the ICS MEL questionnaire. And the advantage is the incontinence questions are there, and the bother related to each and every symptom of the patient is evaluated. It includes 13 symptoms in the short form and 23 symptoms in the long form. And it almost takes 4 to 5 minutes for a patient to complete the form. Then comes the role of urinary diaries. So the aim is to estimate the voiding frequency, the fraction of urine production during the night, mean voided volume, and also the functional bladder capacity, which is the single largest void usually in the morning. And Bright in 2014 derived that the optimal diary duration should be at least 3 days. But for practical purposes, we instruct the patient to keep it for 2 days and usually in the weekends. There are 3 types of urinary diaries. One is the micturition chart, which records the time of each micturition for at least 24 hours. Then come the frequency volume chart, which include voided volume and time of each micturition during the day and night hours. And then if we include fluid intake, incontinence episode, degree of incontinence, pad usage, and degree of the urgency, then it becomes a bladder diary. The only validated bladder diary is the ICIQ bladder diary, which is to be kept for 3 days. And if we zoom in the details, then it includes the time of the void, the kind of drinks the patient had, the amount and the type, then urine output, which can be measured by a simple pot, and the sensation of bladder which patient felt, that is again coded like 0 to 4 in the form of no sensation or normal desire, urgency or with urgency with leak. And if he is using pads, the number of pads which needed to be changed in the day. Another presentation of BPH can be urinary retention, which can be acute or chronic. Acute retention is defined as sudden and painful inability to pass urine voluntarily. And the types are spontaneous, which is associated with the previous history of LUTS, or it can be precipitated, which is inability to urinate following a triggering event. While the chronic retention is defined as a non-painful bladder, which remains palpable or percussible after patient has passed the urine, or it can be persistent post-void residue more than the bladder capacity, but exact value is not defined in different studies, while it can be in the range of 350 cc to 1000 cc. So the first definition will be more accurate. Then the presentation can be with the associated complications of the BPH, such as stones, which symptoms include strangury, dysuria, or hematuria. There can be recurrent urinary tract infection due to a significant post-void residue or a recent history of instrumentation or catheterization. And it can be with or without the pyelonephritis and high-grade fever or rigors. Then comes diverticulum, which can be due to chronic obstruction, and it can be due to high pressure voiding. And again, if it doesn't drain, then it can lead to recurrent urinary tract infections. And another presentation can be hematuria due to a very large prostate, and it causes some kind of a capsular stretching, which leads to ruptured capillaries. On the part of the examination, of course, the examination of the external genitalia, the suprapubic area, and the hernial orifices is very important. But the main thing is digital rectal examination. And it is very important to grade the prostate into 4 grades, that is 1, 2, 3, and 4. And 3 main aspects are to be noted: the median sulcus, the lateral sulcus, and the upper limit. So the grade 1, the median sulcus is shallow. and lateral sulcus is 1 finger width, and the upper limit is easily reached. In grade 2, the median sulcus is prominent, the lateral sulcus is 1.5 finger width, and the upper limit is reached with little efforts. In grade 3, the median sulcus is obliterated and lateral sulcus is 2 finger width in the size, and the upper limit is reached with a quite significant difficulty. And in grade 4, again the median sulcus is obliterated, lateral sulcus is more than 2 finger width breadth, and the upper limit cannot be reached. Also, the consistency of the prostate gland is to be noted, which is usually like a tip of nose in the case of BPH, where it can be hard in the case of CA prostate. Then comes the diagnostic part, which first includes blood and urine tests. The blood test includes complete blood count, serum creatinine, and urine routine micro. Then comes the role of serum PSA, which is not necessary in every case. Each and every guideline writes that. And opportunity screening is agreed upon if the age of the patient is above 60 years, and if it is talked and discussed and consented with the patient. And of course, if there is any doubt on digital rectal examination, then serum PSA is a must. There are few newer serum biomarkers for BPH which needs to be discussed. One is the BPSA, which is excreted by the transition zone, and its ratio with the free PSA is very sensitive for diagnosing the BPH. Then comes the P2526, which is a monoclonal antibody from the seminal plasma of the BPH patients, and it can be tested with ELISA. And JM27, which is a gene encoding the JM27 protein, which is usually upregulated in the patients of BPH, and it can be tested by the microarray analysis. Then, of course, comes the role of uroflowmetry, which is a common office investigation in cases of LUTS. And rather than the routine bell-shaped curve, the curves in the cases of BPH can be longed and protracted. Also, they are elongated and increased curves. The Qmax is usually long and it is decreased in the number, and the pattern can be intermittent, which can be suggestive of staining, and we can also note the hesitancy. And the Qmax, the value are divided into 3 categories. If it is more than 15, then it is considered normal. If it is 10 to 15, then it is equivocal. And if the threshold of the Qmax is less than 10 ml per second, then it has a specificity of 70% and sensitivity of around 50% to diagnose the significant bladder outlet obstruction. The next investigation in line would be ultrasound of the kidney, ureter, and bladders, and we can see all the significant findings in these images. One can be the large median lobe, which has to be assessed in every patient. Then bladder wall can be thickened due to chronic obstruction. Patient can have high post-void residue, which can be calculated by the help of ellipsoidal formula in the transverse and the sagittal view. Also, patient can have bladder diverticulum, which can be seen in the ultrasound very easily. Also, the assessment of the diverticulum post-voiding, if it is draining completely or not, can be seen in the ultrasound. There can be associated bladder stone, which can be noticed during the bladder level ultrasound. And of course, we can see the dilated upper tracts if they are there in the case of BPH. And then comes the role of transrectal ultrasound. Main 2 things are to be noted. One is the size of the prostate, again, which can be used, which can be calculated by the ellipsoidal formula, which is length into width into height into 0.52, which is approximately divided by 2. And it can be calculated in the axial view and the longitudinal view. The physiological changes with the progression of the BPH, as Dr. Radhika already discussed in the anatomy slide, that usually the normal prostate is triangular in size. And as the sequence go from B to C to D, we can see that it is from triangular to slightly ellipsoid, then more ellipsoid, and at the end it is circular prostate. So not just the size of the prostate, but the shape of the prostate is more significant to determine if it is significant obstruction, and if the patient will be helped with any intervention can be assessed by this circular prostate in the transrectal ultrasound. There are indices which can be noted in the TRUS examination, which includes the transition zone index, in which we calculate the area of the transition zone and divide it by the total gland area. And if it is more than 0.5, it is very significant. Another very discussed about index is the PCAR, which is presumed circle area ratio. And again, the same concept that obstructive BPH, the AP diameter increases more than the transverse diameter, which leads to a more circular gland rather than a normal triangular gland. And the formula is seen here, which is divided S upon the S dash, which is the ellipsoidal gland upon the circular gland. I would like to add one slide on the role of urodynamics, and there are only a few indications of urodynamics in the patients of BPH, which are to be thought about before proceeding with the medical or surgical management. These are patients with previously unsuccessful invasive treatments, or patient who cannot void more than 150 ml, patients with PVR volume greater than 300 ml, patients who are older than 80 years of age with predominantly voiding LUTS, and patients younger than 50 years of age who are predominantly voiding LUTS. And two types of UDM patterns can be noted. If it is high pressure and low flow, then we can say that it is a high pressure bladder outlet obstruction. And if it is low pressure and low flow, then we can say that it is associated with the detussor underactivity. But the detailed discussion on UDM is out of the bound of this presentation. So I would like to conclude. Thank you.
That was nicely covered, Kavan. Thank you. Is Aisha ready now with her presentation?
Yes, sir.
Aisha is ready, yeah.
Okay, great. Let us start with her again.
There is some problem with audio and video quality for some of the viewers. Possibly those who have joined on mobile, because majority are viewing it quite okay. So still, if there is some problem, maybe due to local mobile network problems, still we'll try to solve those also. Abhijit, if you can try and do something about it, we'll try about it.
Yes, sir, I've seen almost. I think the good internet should be the solution, and we can see it properly on YouTube, sir. And I think, sir, Aisha is ready, sir.
Great. Over to Dr. Aisha.
Dr. Aisha, kindly share your screen.
Before Aisha comes in, can I just make a comment?
Yes, sir.
Yes.
Both
Sure, sir. Go ahead,
both
sir.
presentations were absolutely fantastic. Absolute to basics, and that is what we aim at. Wonderful.
Actually, sir, that's the sole idea, so that the residents all over the zone get interested in academics.
Absolutely.
And we should extend this idea of giving them opportunity for the different residents from different places, so that they have that courage also to present in front of so many people, and also they will study those topics in deep depth.
And it has to start with basics, absolute basics. That's where it starts. Very good.
Over to Ayesha. We can see your presentation.
Okay, sir. Good evening, sir. Today I'm going to present pathology and pathophysiology of benign prostatic hyperplasia. As the name suggests, it is characterized by increase in number of prostatic cells in transition zone of prostate. It is basically the imbalance between the epithelial and stromal cell proliferation and impaired apoptosis. In BPH, it is prevalent. It is an age-dependent disease. It is more prevalent in with increasing age. The prevalence increases with each decade by 15%. And in 100% of 90-year-old male, BPH is seen. Though the pathophysiology of BPH is not clear, there are multiple factors which play a role in its pathogenesis, either singly or in combination. Coming to the various etiological factors causing BPH are hormonal, growth factors, stromal epithelial interactions, impaired apoptosis, inflammation, metabolic causes. This figure is showing various factors involved in BPH, such as autoimmune, hormonal changes, infection, inflammation. All these factors induces the release of cytokines and chemokines and growth factors, which again results in epithelial proliferation and stromal proliferation causing BPH. Coming to androgens, which is testosterone and dihydrotestosterones, though they are not directly related to BPH, but they are required for cellular proliferation and differentiation. For an individual to develop BPH, prostate needs to be exposed to androgen during the embryonal period. Here it is showing the mechanism of action of testosterone leading to proliferation of stromal and epithelial cells. It acts both on stromal and epithelial cells. In stromal cells, it gets converted to more potent form, which is dihydrotestosterone. It binds to the androgen receptor and causes release of growth factors, which also affects the adjacent epithelial cells in paracrine manner and results in proliferation of those cells. Estrogen also plays an important role in BPH pathophysiology due to aromatization of androgens in the peripheral tissue in the presence of P450 aromatase enzyme. It also binds to AR receptors and increases these growth factors, resulting in proliferation. So basically, the imbalance between these factors, either it can result in increased cellular proliferation or reducing the apoptosis, leading to increase in the number of cells in the transition zone. Various theories related to BPH are embryonal reawakening theory and stem cell disease. Both I will be explaining in this diagram. In cases of inflammation and tissue damage near the prostatic urethra, it results in mesenchymal stem cell recruitment, which further causes disruption of smooth muscles and stroma, and it stimulates the stem cells near the prostatic glands, causing episodic inductive reawakening. Due to recurrent insults, recurrent inflammation in the prostatic tissue, it causes the increase in number of cells, causing proliferation and accumulation. Coming to the pathology of prostate, McNeil demonstrated involvement of transitional and periurethral zone of prostate in BPH. Primarily, it involves the periurethral tissue just proximal to the preprostatic sphincter, later involving whole transitional zone. Now, histopathology of BPH, it shows the proliferating glands and fibromuscular stroma. It is the hyperplasia of stromal and epithelial cell, not hypertrophic process. In the first phase, there is increase in number of nodules, and in the subsequent later phases, those nodules get increase in the size, causing the LUTS symptoms. One of the unique features of human prostate is the presence of prostatic capsule. It also plays an important role in pathology development of LUTS. As the prostatic tissue increases in the transitional zone, this capsule transmits the pressure over the urethra, causing its compression, leading to obstructive LUTS symptoms. Again, BPH also depends upon the anatomical pleomorphism of the nodule. If the nodular enlargement is seen in the median, and the third picture is showing both lateral lobes and median lobe involvement. The pathophysiology of BPH is a complex interaction between the urethral resistance, bladder response to the obstruction, and the prostate hyperplasia, which is causing all these changes. So the understanding of BPH requires detailed insight into obstruction-induced bladder dysfunction. Apart from that, as BPH is seen in elderly male, the other causes also confound, and it will also affect the lower urinary tract symptoms, such as in diabetic, polyuria, and neurogenic disease, detrusor aging effects, and other primary bladder diseases. Apart from epithelial and stromal tissues, prostatic smooth muscle also plays a significant role in the pathogenesis of BPH. The prostatic smooth muscle, active tone and passive tone. Active tone is regulated by adrenergic nervous system, especially alpha-1A receptors. The stimulation of these receptors causes increase in prostatic urethral resistance. Alpha-1A receptors are more abundantly located in the prostatic smooth muscle cells. Here comes the role of our medical management of BPH. Now coming to the bladder's response to BPH. It is not just related to the mechanical obstruction and which results in obstructive LUTS symptoms. The two basic obstructive induced changes in bladder are detrusor instability or decrease in compliance, or else the reduced detrusor contractility, which causes obstructive LUTS symptoms. This factor explains that even after surgery, approximately 1/3 of the males continue to have significant irritative and storage symptoms because of this detrusor changes due to chronic obstruction from benign prostatic hyperplasia. Gosling demonstrated major cystoscopic changes in the bladder due to chronic obstruction due to BPH, which is trabeculation. These are caused by increase in collagen deposition. Severe trabeculations are associated with significant post-void residues. One more study, it demonstrated the bladder wall remodeling, and it says that it is involved in three phases: hypertrophic, compensatory, and decompensation phase of the detrusor muscles. These are the various factors which are responsible for complex bladder response in BPH, where urothelium, suburothelium, detrusor, matrix, and hydrostatic pressure due to obstruction, all these factors involve in causing the complex LUTS symptoms due to the bladder outlet obstruction. What are the challenges in understanding pathophysiology of prostate? All these studies are done in either murine model, that is rats, or canine models, which are very different from the human prostate in anatomical perspective and physiological also. So that's why we need more studies involving human prostate. And human prostatic urethra is also challenging to replicate in vitro. Underlying pathophysiology of BPH remains incompletely understood, and there are alteration in local hormonal, inflammatory, and stomal environment near the prostatic urethra, which contributes to prostatic hyperplasia. As our understanding of pathophysiology of BPH improves, we can direct therapies targeting underlying disease process with improved tolerance and reduced risk of disease progression. Thank you, sir.
Thank you, Aisha. That was a very good and concise presentation. Thanks for keeping to time.
Thank you, sir.
Next speaker is Dr. Vivek Birla. Subodh is the best person to introduce Vivek.
So Dr. Vivek Birla is one of the senior most urologists in Mumbai and practicing in Thane. He has his own setup and has been instrumental in a lot of teaching that goes around in the circuit. So without much of a delay, let me introduce you to him and let's start his talk.
Thank you. Good evening, friends. After I think Dr. Aisha's lecture, my job has become very simple. So we are starting with medical treatment of, how this has happened. One sec. Yes. So coming to medical management. Medical management is basically a drug management. But when we start drug management, in many of these patients, the lifestyle modification advice is extremely important, which relates to modification of water intake and management of constipation. I think if both these factors are taken into consideration, many patients will get benefited much more than probably when we start with them with alpha blockers. So it is very important for all of us to understand the history of the patient, nocturia part or your frequency part, and then accordingly suggest them how the water intake has to be taken, or how should they cut down on caffeine intake, or how should they cut down on alcohol intake. And along with that, management of constipation plays a big role. Many of these patients, elderly, are constipated. If you are not taken the history properly and if you are not managed the constipation, you probably may not get an equally good result with starting alpha blockers. Now, next is main drug therapy, what we are dealing with. Now, in this, the way Aisha said about alpha blockers, so that is alpha receptors. So you had started with prazosin, doxazocin, terazosin, alfuzosin, tamsulosin, silodosin, all these molecules. So when we were just passing out MCH in year 1993, that is the time I think terazosin started. That was a hytrine, which had become very prominent and famous molecule. Then second group of drug is 5-alpha reductase inhibitors, which are basically stop conversion of testosterone to dihydrotestosterone. In that you have finasteride and dutasteride. Then additionally, in last few years, we have come to know the role of PDE5 inhibitors, which is mainly tadalafil, what is done, which is used in low dosages. Third or fourth group of drugs is bladder relaxants, which are solifenacin, darifenacin, now mirabegron, and sometimes fesotoridine. And then combination of all these drugs, whenever the symptoms are of different nature in lower urinary tract symptoms associated with BPH. Obviously, I am not going to stress here because some of these patients do present with urinary tract infections when we try them or put them on antibiotics or antiseptics or nitrofurantoin or your sulfamethoxazole trimethoprim or more number of antibiotics. So that also becomes a part of drug therapy for all these patients. I am not going to cover surgical part, but obviously when we are giving the patients on a drug therapy, we should be aware of red flags. So if patient is landing during follow-up with retention, either acute or chronic retention, how is the post-void
Some
residue?
net issue,
How are the
Vivek.
hello? Yeah. Hello. Am I audible?
Yes, sir.
Any
Vivek
problem?
sir, we are hearing you clearly. Slides are going on smoothly. Please continue.
Yeah, okay. So while the patient is put on a medical line of treatment, it is very important for a urologist to understand that what are the red flag signs where probably the stoppage of medical treatment and some further treatment in the form of surgery may be advisable. So that we all should know related to retention part, stone formation, infection repeated episodes, hematuria, and all these things. Now, strong recommendation is there by guidelines, EAU as well as AUA as well as USI guidelines that alpha blockers are used for moderate to severe symptoms of BPH. Now, just to cover up on few drugs, that is, see, hardly we use now toxazocin or terazosin or prazosin. They are all into a hypertension treatment management zone. So we are talking about tamsulosin, silodosin, and alfuzosin. These are the three most commonly used drugs by urologists for all this. Tamsulosin was approved in the year 1997, where we thought that probably it is much more selective than terazosin, and that is why we thought that it has much lesser cardiovascular side effects as compared to terazosin, and that's why it became more popular. Most of the urologists started using tamsulosin. Then came silodosin, which got approved in 2008. It thought to be much more selective than even tamsulosin, and that's why it had a list of side effects. So probably related to postural hypotension, side effects were very, very less, and it became more publicized, more promising, and even it was got promoted more by pharmaceutical companies from that angle. Alfuzosin is again very commonly used molecule. It is approved in year 2003, and it is more popular because in a younger population where there are a lot of significant LUTS symptoms, there the alfuzosin plays a very important role because it preserves ejaculation in majority of the patients. So alfuzosin is an extremely important molecule where even younger as well as elder patients would like to preserve their ejaculatory abilities. Now coming to dutasteride, finasteride, they are 5-alpha reductase inhibitors. So basically they are used thinking that probably they would shrink the prostate size. Earlier drugs, alpha blockers, were not meant to shrink the prostate size. They were supposed to relax the prostatic capsule in the bladder neck area, allowing bladder neck area and a prostatic urethra to open up so that the patient is able to pass urine little more comfortably. Obviously, with alpha blockers, you would never get a result. What you would give the result of a urine flow rate by operating on these prostates, by opening up the prostates. But obviously, surgery has its own set of complications. So not that every patient undergoes a surgery. Majority of the patients in today's era, we are treating them with a medical therapy alone. Now, these alpha reductase inhibitors are basically used when the prostate size is bigger. So probably the literature says that it should be used where the prostate gland is more than 30 grams or 30 ml on a sonography. Again, sonographically, obviously there are so many sonography centers, all mushrooming all across our west zone or any zone for that matter. So many times you see a fallacious sonography reports where you see on a rectal examination a huge prostate and the sonography report says that it is a very small prostate. So when you probably recheck it with some other sonography centers, you realize that no, the first sonography report was really wrong. So you should believe in your own rectal examination findings also when you are starting all these medicines. Rectal examination would play an important role in the size of the prostate gland, and secondly about the hardness or nodularity to look out for a possibility of a cancer. Many times we see a patient treated by general practitioners or physicians for 2 to 3 years where the rectal examination is not been done at all. Patients PSA sometimes remains once it is done, maybe around 5, 6. Patient is put on medical line of treatment. Later on, he comes for a urology follow-up. We do a rectal examination, and probably the prostate cancer was missed out totally. So we should be very careful in all these patients. So dutasteride and finasteride are the molecules which are used mainly in patients who have a larger prostate on rectal examination as well as on a sonographic examination. Now, the era has come where we have started having various combination therapies like alpha blockers with 5-alpha reductase inhibitors, which has been in vogue for a very long duration now. Nowadays, alpha blockers with PDE5 inhibitors like tadalafil, which is majority of them are with 5 milligram tadalafil, and some patients where alpha blockers and anti-muscarinic drugs or muscle relaxants, what we call them as, are used where you have more of a storage symptoms. Now, main dilemma which comes that which patient should be put on tamsulosin or silodosin. So my take on this is, see, tamsulosin is a little cheaper drug. All this population, what we are using are is retired population. Majority of the population is from a lower and middle socioeconomic strata, unless you are treating majority of very rich patients. But still, as a common urologist, we see many of these patients who are non-affordable. So we should see to it that we use these drugs very selectively, very appropriately, looking at a cost factor. I'll tell you simple logic. Tamsulosin and silodosin comparison. Tamsulosin tablet along with this banana and egg is possible if you don't give silodosin. In silodosin, this will be missed out. You cannot give, or person cannot take egg and banana on that day, just to simplify it. So tamsulosin tablet costs you approximately 10 to 12 rupees. Silodosin costs you around 30-35 rupees. As a urologist, many times we don't give consideration to this unless and until patient tells us sometimes की सर थोडी स्वस्त गोळी मिळेल का हो, ही जमत नाही, आता बरीच वर्ष चालली आहेत आमची गोळी. Now coming to postural hypotension, tamsulosin it is little more common obviously. Silodosin it is less common because it is more selective. Ejaculatory disturbances, tamsulosin it is less common, silodosin it is more common. Nasal stuffiness and slip disturbances are more common with silodosin, less common with tamsulosin. Irritative, bladder irritative symptoms, or the person having a more bladder storage symptoms, silodosin probably is better molecule than tamsulosin. Efficacy wise, personally I feel, as well as the literature says, that most of them, both tamsulosin and silodosin have almost similar efficacy. Onset of action, silodosin is faster, so probably when patient is likely to be has gone into acute urinary retention, there probably it is worthwhile giving a silodosin molecule to start with so that you have a faster onset of action. Intraoperative floppy iris syndrome is more common with tamsulosin as compared to silodosin. This is very relevant that we must tell all these patients because they are elderly population likely to undergo a cataract surgery. So they should inform their ophthalmologist when they're going for a cataract surgery that you are already on tamsulosin or silodosin. Sometimes this floppy iris syndrome can be a very troublesome issue for ophthalmologists to treat. So they should be aware of it. So they keep some instruments ready. Most of them nowadays keep it ready because they know that most of these patients would be there. But it is very important for a urologist to convince patient that they should tell this, that he is already on this tablet if they are undergoing a cataract surgery. Now, guideline recommendations for various combinations. When you're giving them this alpha blocker with the tadalafil, it is usually used in a younger population where probably erection is also a concern. And many of these patients will have a feel-good factor because their early morning erections are a little better, their penis little becomes stiffer, so they are able to void little better. Now, when it's coming to alpha blocker with anti-muscarinic or bladder relaxants, obviously you're giving them when there are more of storage symptoms. So obviously you put them on alpha blockers first, then see how the symptoms, or unless the patient has presented with a lot of storage symptoms to begin with, then probably it is worthwhile adding both these drugs together. So in short, The message is medicines for BPH is a long journey now, 32 years of journey. Why I'm stressing this? Because many of these patients would be put on long duration treatment and they would always have that question, Sir, याचे काही side effects होतील का? So it is very important for us to tell that it is a very long duration that all these drugs are there in the market. Lots and lots of patients have taken them for 10 years, 15 years, 12 years, whatever that duration, with not significant side effects. I usually explain them that every day you go for a job, you cross the road. Sometimes maybe once in 20 years, 30 years, you may end up with some accident. Minor or major, it is your nasib ka khel. So the same way, the safety is good of these drugs. Now, when you consider or decide about the choice of drugs, you should always see the safety profile, efficacy, and cost, which is extremely important, which many of us do neglect. For larger prostates, consider adding a dutasteride or finasteride. For bladder storage symptoms, we always give bladder relaxant so that their symptoms improve. For associated ED or for a younger population, probably the tadalafil either in the form of 2.5 milligram or 5 milligram together would work well. Now, last but not the least, many of these patients are elderly, they have a lot of comorbidities, so polypharmacy is extremely common. Many of these would be taking diuretics, many of these patients would be taking various amounts of diuretics in the combinations from a cardiac point of view. So it is very important that you see what the tablets are going on. I always see in my practice, I always tell the patients, please get all your medicines, what you are using, at least once during the follow-up so that we know what medicines are going on, so that we can advise you, suggest you. Otherwise, we are giving here bladder relaxants and their patient is taking diuretic dosages and nothing is working. So you are absolutely clueless. So it's very important that we look into all the drugs, what the patient is taking during our follow-up. Second most important is drug interactions. So it is very important that we always see, is there any drug interaction happening? What drugs are we giving? What drugs patient is taking? So that is the second point. And the third point is, these also patients should be regularly follow up. Now probably we are into 30 years of practice. So we realize that patients we had seen them in early years of practice, we had put them on alpha blockers. Patients were happy, so they continued taking. And later on, 10 years later, 12 years later, they have landed up with cancer prostate. So many of these patients would continue to take medicines in spite of not telling us because they feel good about it. But we have missed out on the CA prostates because they have not followed up. Or we have missed out on complications like chronic retention or back pressure changes because they have not followed up. So it is very important that we educate these patients who are on medical treatment that a regular follow-up, regular checking by uroflowmetry, and maybe doing a PSA or a rectal examination at least once in a year would be very important to treat these patients in a proper way. Thank you.
Thank you very much, Dr. Vivek Birla, sir, for a very crystal clear kind of thinking and a very hard hitting message, uh, going through many scenarios which would be of value to all the young practitioners as well as to the practitioners who have a dilemma of using the drug. I just have one question for you, sir. What is your PVR threshold before you start thinking of giving either anticholinergics or the beta agonists? Is there a fixed value volume that you would stop at, or you would not worry about it?
No, usually if person is having more than, it is pre-void as well as post-void, both are equally important. So if pre-void is, say, he has a bladder volume which is around 600 ml, and if he's retaining only 50-70 ml inside, but he has more of storage symptoms also associated, then mirabegron and all these drugs would work well also. But if person has just 200-300 ml pre-void, and out of which maybe 100-150 cc is remaining inside, then probably I would be skeptical starting on this bladder relaxants. But some of these patients with a mirabegron, probably it does not aggravate the retention or post-void residue. So worthwhile, sometimes if the need is there, you can give it a try and see whether the bladder relaxants are helping him like mirabegron.
Okay. Thank you very much. Thank you.
Can I just say something?
Sure, sir.
Dutasteride is clearly known to cause collagen deposits in the bladder. And that is why alpha blockers can be continued for long time. But there's a limit up to which you can have a dutasteride combination with it. What's your view about it, Vivek?
In fact, literature wise, they say that if the combination therapy is being used, probably you may use it for first 6 months and later on continue with just dutasteride, because probably you are allowing the prostate to shrink and probably symptoms will reduce. But in clinical practice, what I always see is if the patient is symptomatically better, uroflows are relatively okay, and the post-void residue is less. In fact, I switch off both alpha blockers as well as dutasteride, even if it's a combination is going on at the end of 3 months or 4 months. Maybe because a lot of these patients would have a remission period where they are symptomatically good. But if they remain symptomatically good and their uroflowmetry is also okay, then I will switch off both the medicines. Maybe when I follow them up, maybe 2 months, 3 months later, and I check that uroflowmetry is deteriorated or post-void residue is increasing or symptoms are appearing, then maybe we can justify it in restarting. That is the first. Then second, people say that dutasteride has a very long half-life. So should we give it every day or should we make it once a week? So that is also probably we don't have enough studies to document this. But clinically, at least in our area, there are some urologists who are giving dutasteride only once a week. And they feel that they have got a very good results with that also. Though it is not scientifically monitored and scientifically presented data.
Good. Thank you.
Vivek,
Yes, sir.
there's one question. How long one should continue the medical management? Is any time duration for medical management? How long we can continue?
See, if the patient has improved well, his uroflowmetries and post-void residues are all in a comfortable range, then probably I continue the medications for 3 months and then I switch it off and tell them if you have any symptoms, come back, or 1 month later we'll check your uroflowmetry, post-void residue. If the reappearance of symptoms or all these things are changing, then probably I restart them. But there's no hard and fast rule ki how long you can continue or when to switch off. Unless on a follow-up you find that some red flag signs are appearing, like something which is probably going to need a surgery, then probably you would definitely switch off the medicines and go for surgery. But otherwise, if the patient has improved well, I always switch them off with the medicines after maybe 3 months or 4 months.
So your suggestion is intermittent therapy, continue it for 3 months, see the response, titrate it, and if come back again. So
Yes.
Vivek, it was really great insights, and somebody who's in 30 years in practice, here you are given a comprehensive how to use medical treatment, at the same time how to consider other pharmacological treatment which is going to overlap. So should be a good take home message for majority of us. Now we'll proceed to the next speaker. Sabnis sir is going to talk on open prostatectomy, and I don't think anyone needs introduction of Dr. Ravindra Sabnis here in West Zone, but some.
Sir, you are muted, sir.
One sec. I don't think anyone needs introduction of Dr. Ravindra Sabnis. He is going to talk on open prostatectomy. Actually, originally Kirpekar sir was going to talk, but he had gone to Prayagraj for Mahakumbha. So he has joined as a expert panelist. But Dr. Sabnis sir would be talking on open prostatectomy. Most of our residents and younger generation has practically forgotten about open prostates, which was once upon a time bread butter for general surgeons also. Dr. Sabnis was senior lecturer when I had joined in urology. So he's one of my mentors since then. That is 1992. So sir, over to you, sir.
Thank you, Vilas. Thank you very much. Let me just share the my slides. And well, as you rightly pointed out, that open prostatectomy, I don't think that your generation has seen or have understood what exactly the open prostatectomy means. In our institute also, we generally do about 1 or 2 open prostatectomies in a year just for demonstration, and all the residents they gather. I mean, this was a scenario which was not thought of when I was a resident and I was lecturer in Sion Hospital, and you have witnessed for that. Well, in our era, when we were residents and after passing out when we were lecturer, that time TURP had come, but the indications for TURP was the prostate which is less than 40 grams. This was a standard teaching and exam answer. Anything more than that was considered to be the open surgery, simply because that time the camera was not there and so many other things were not there. And therefore, in our time, we were all very much used to open prostatectomy. And I'm very happy that Dr. Kirpekar, who is the pioneer, and in fact, he demonstrates the open prostatectomy every year. His word is taken as a final when it comes to prostatectomy or prostate surgery. And he's there with us today as an expert panel. So at the end, I will ask him to comment upon this. But let me tell you what exactly the open prostatectomy means. Well, there are 3 main approaches for the open prostatectomy. Retropubic prostatectomy, which is also called as Millin's prostatectomy, transvesical prostatectomy, also called as Frere's prostatectomy, and perineal prostatectomy, also called as Young's prostatectomy. Mind you, these are all simple prostatectomy, not the radical one. Mandatory for before doing any open surgery is cystoscopy, because if you have to see any lesion, if you have to confirm the size, how exactly the orifices are, where they are situated, median lobe, lateral lobe, capacity, trabeculations, all these things are mandatory to be seen, and therefore cystoscopy is the first step of doing any surgery. In nutshell, if you have to describe what exactly is the sorry, you are able to see, no?
Yes, sir.
Yes, sir.
Yes, sir.
So,
Yes, sir.
Frere's prostatectomy, what does it mean? Is that it was invented by Saint Peter's Freres. It was extremely common surgery in the era where TURP was just coming, or before the TURP came in. Very common. It was very common for the general surgeons to do it. When it became urologists would shift to Millin's prostatectomy. That is how in the old era, the surgeons and urologists were differentiated. The one who does Frere's prostatectomy is general surgeon, and the one who does Millin's prostatectomy is urologist. Well, Frere's prostatectomy, that way, is the blind procedure. Hemostasis is just by packing. You just enucleate the prostate, pack, and then job is over. The flip side is that incontinence rate was high, especially because you were enucleating and pulling the apex by the fingers, and therefore jeopardizing the integrity of the sphincter. Millin's prostatectomy was the advance after the Frere's prostatectomy, because it was described as a most anatomical operation. Hemostasis was precise and under vision. Urethra was cut under vision, which has an immense benefit. Bladder neck, which is well retracted, could be resected, and incontinence was not all that common. This was the original article published by Millin's, the first 20 cases. How many years back? So many years back. And this was the beginning of the open prostatectomy, Millin's prostatectomy era. What are the essential steps? You open the prostate, go into the retropubic area, see the bladder, see the prostate, and you see here, you will see the junction of the bladder and the prostate. Remove all that fat, so the prostate is very clearly seen and junction is properly noted. Now take hemostatic sutures. I will show you that in the video. But these are the hemostatic sutures which you have to take proximally and distally. And in between the hemostatic sutures, you take the incision either with the scissor or with the cautery. Then as you go cut the capsule, you see the adenoma. Then either you dissect with the scissor and go into the plane between the capsule and the adenoma, which means that the capsule is nothing but the compressed peripheral zone, and you get into that plane. That plane is very clear cut. It can be demarcated, and as you start enucleating, automatically you will get that plane of cleavage, which we are very fond of seeing that cleavage plane when we are doing laser prostatectomy nowadays. But this can be dissected by scissor or by finger. Once you enucleate the lateral and then take out the median lobe or the upper part, then you catch hold of that median lobe with the valsellum or the Ellis forceps, and then dissect out the posterior portion, separate it out from the posterior capsule, and that is how from the side, from the posterior and from the anterior, you go to the apex. Don't dissect the apex too much. Now you can see here that this is a retractor. This is the bladder neck from where the posterior thing is going on, and bladder, this retractor is retracting bladder neck. There will be ureteric orifices here. Now, once you cut under vision, the whole prostate is out, and this is what is the area you will see. This is the prostatic fossa. This is the bladder neck, and this is the bladder. You see that this is orifice here, this is orifice here, and this is bladder neck retractor. Now, what is shown here is extremely important. So these are the hemostatic sutures. What you do is that when you are at the junction of the lateral, as Radhika Sapekar pointed out, the vessels which are coming into the prostatic capsule are from the side, and therefore you take a stitch going from outside in, going into the bladder neck and coming out, and then tight. Now this will make a hemostat. This is called as hemostatic sutures. Once you do that, then the important part is the bladder neck wedge resection. It is part and parcel of the Millin's prostatectomy. Now, what does it mean? That whatever is the elevated bladder neck, you take a V-shaped incision so that this bladder neck gets cut. And then the mucosa of the trigone, which is there, actually is sutured to the prostatic fossa here. That is the raw area which is covered. So this is also called as wedge resection of the bladder neck and re-trigonization of the bladder neck, so that bladder neck is taken care of, and that prevents the post-operative bladder neck stenosis. After Millin's prostatectomy, hardly ever you will see the bladder neck stenosis. That is because of this stricture. Once you do that, then the anterior capsule is closed and the job is over. Now, I will show all these steps one by one into the video format. This is the Millin's retractor. It is very, very important that you have the Millin's retractor. It is shaped in such a way that once you take a phalansteal incision, you retract on the side, and this is third blade which actually retracts the bladder. This is the valsellum which I was talking on, which can be hold to of the median lobe. This is the angled, also called as Turner Warwick needle holder. It has a peculiar angle so that you can take a stitch which is deep in the pelvis, and this is bladder neck retractor which retracts the bladder neck. So these are essentially the instruments. Now, step is that you take the phalansteal incision. Everybody knows phalansteal incision. Once you cut the muscles, cut in the midline, separate it out, rectus is separated in the midline, and that is how you enter into the retropubic space. Once you go into the retropubic space, you put the Millin's retractor, and then this is a step where you put a gospis or the small this on the side of the prostate, which stabilizes the prostate. This is the hemostatic sutures. You see that depending on the size of the prostate, you take hemostatic sutures distally and proximally. In a big size prostate, you take 3 stitches, which will prevent a lot of bleeding because there are plexus which runs on the bladder on the anterior surface, and these hemostatic sutures actually will prevent the bleeding when you are actually taking the cut on the anterior prostate. See now, these are the 3 sutures here, 3 sutures corresponding proximal distal, and now you cut the anterior capsule of the prostate. Go deep so that whole prostate is cut, and you actually see the adenoma which is glistening white. You can see this adenoma surface. Once you see that, either you put a scissor or you put a finger and then go laterally on both sides. Idea is that when you enucleate, go on the lateral side on the left as well as on the right, and then come out in the medial part. Now this is how you have separated. You have taken out the finger from here, and now it is attached only in the posterior area with the valsellum. You separate it out under vision. You cut the apex. This is how you cut the apex with the scissor. And once you cut that apex, the whole prostate is in your hand, and pack the fossa, whatever fossa, so that hemostasis is achieved. This is what is the prostate which is removed completely intact, and this is what is the fossa which is seen. most of the times the fossa becomes clear once you take hemostasis suture. This is what is a bladder neck wedge resection. Now you see that there's a V-shaped incision which is taken on the bladder neck with the cautery, so that this is the raw area which is created. You see the orifices here, one orifice here, other orifice here. Already the feeding tube is put as a safeguard. And now this is a raw area which is created. Now that raw area is sutured with the Vicryl, 30 Vicryl, so that it is called as retrigonization of the bladder neck. This is one single step which has prevented the bladder neck stenosis. It was a phenomenal invention. And therefore, bladder neck resection is a part and parcel of the every Millen's prostatectomy. Once you do that, you have taken the sutures on the lateral side, you have sutured the posterior part, and now your bladder neck is properly reconstructed. Now you start suturing the anterior capsule. Now this is once you dissect, suture the bladder neck, you come on the lateral side and then start suturing the anterior capsule. This is anterior capsule. Now you have started suturing. This is what is the transverse cut which we had taken. Start from one side, start from the other side, and tie the knot in the center. That is how it is recommended. Quite often, if you don't take the proper incision and take a short incision or a small incision, then this becomes ragged. Now this is how the anterior capsule is completely cut. This is what is the end view of the completed prostatectomy. And at this point of time, you ensure that the urine is properly clear. Give a little bit of a washes, because sometimes there can be some clots which can block the catheter. Most of the times, once you do a proper hemostasis under vision, urine becomes clear. And you can see here that at the end of the, when you are closing the thing, the urine is clear, and this is what is a big prostate. And most of the times, the post-operative period, they have a good uroflow and a very good continence. Now, if nutshell at the end, if I have to compare three main prostatectomies, I am not describing Frere's prostatectomy because more or less same. The difference is that you don't dissect out the retropubic space. You just dissect the bladder, open the bladder, and once you see the bladder, take the incision on the posterior surface of the median lobe, and from there you insert the finger. It is also called as this anterior commissure, which is broken up. Then enucleate on both sides and pull the prostate outside. This is blind procedure. There are a lot of vessels which keep bleeding, and therefore you have to pack the fossa, press it for 5 minutes, and majority of the bleeding can stop. So high mortality is the transvesical. Why this Billings came in? Considerable blood loss, because prostate, is a very vascular gland, especially the big gland. And because it is wide, the only thing what you are depending upon is the fossa, the packing. And sometimes if there is intractable bleeding, then you have to just keep a pack for 24 hours and then remove the pack slowly on next day. Lengthy hospital say high incidence of post-op infection and hemorrhage and incontinence was a problem. Transperineal, very lengthy learning curve, incontinence rate is high, occasional urethrorectal fistula, perineal fistula, and secondary hemorrhage. And millions, of course, we have seen it is sometimes a difficult procedure, sometimes difficult to learn, but otherwise there are many advantages which we have seen. And therefore, this is what I wanted to tell about the open prostatectomy, especially the Millen's prostatectomy, which is commonly done now. It was commonly done at that time. I won't say it is done now. It is no longer done now, but it was done at that time. And this is what I wanted to talk about the open prostatectomy. If there are any questions, I will be happy to answer. Thank you very much.
It was an excellent presentation, Dr. Sabnis. Very clear. The video looked clear as well. Just out of interest, what was the size of the gland removed during this video?
This was 150 grams.
And what is the cutoff limit for you for grams or cc
No,
weight of
see,
prostate
grams
that you would consider
for
doing?
open prostatectomy, there is no cutoff limit, a higher cutoff limit. Any gland which can be, which is there, can be removed by open prostatectomy. But nowadays, it all depends on your ability to do the TURP. Nowadays, there are people who are claiming to be doing TRP even for 100, 150, 200 grams. It all depends on your ability. If you see my own practice, more than 100-gram prostates are very rare. Whatever you claim, it is 100 grams or 150 grams. Actually, it is not 100, it's just 50, 60 grams. So if you see my cutoff level, or when I consider the Millin's prostatectomy, when you do cystoscopy, and if your cystoscope barely reaches the bladder neck and you enter with great difficulty into the bladder, that is the case where you just can't do TURP and you go for the Millin's prostatectomy. Now people do HOLAP and robotic, that's a different thing. But this is what in nutshell I would do in our own institute.
Very good. Thank you very much. Any other questions?
Can I comment?
Yes, sir.
Yes,
Ravindra,
sir.
thank you so much for chipping in for me because I was supposed to talk about it.
Right.
Believe me, I did not have such a wonderful video of Millin's. It's so difficult to have a video of Millin's. But I totally agree with you. If my scope can reach the bladder comfortably, I'm happy to do methods which are acceptable with the present standards.
Correct.
But if my scope doesn't reach the bladder, my option today still is a RPP, and it's a retropubic Millin's prostatectomy.
Correct.
Which can give you the best results no matter what, years and years ahead.
Correct.
Thank you, Ravindra, for chipping in
Thank
for
you,
me.
sir. Thank you, sir.
Thank you, Sabnis sir.
Can I ask one small question?
Experience.
Yeah, Dr. Vilas.
Go ahead.
Yeah,
Go ahead.
Doctor, this for to Dr. Sabnis as well, Dr. Kirpekar. You are speaking of scope not reaching the bladder. Is it cystoscope or a resectoscope? Because the resectoscope, the working length is still shorter. So sometimes cystoscope goes in, but the resectoscope does not reach the bladder neck. So which one of these two?
Cystoscope, see, if you know by now, by the time you put a cystoscope, you know that it is very difficult. These are the glands which are very long, prostatic urethra. You have to push and insinuate the urethra to reach the bladder neck and inspect the bladder. So you know that this is not going to be the case for TURP. It is better to do open surgery.
So cystoscope.
Cystoscope.
Yeah, if you want me to show you a video on that, I can show you at the end of the whole session how long the prostatic urethra can be.
Great.
But it's not in the carry on with the program.
Yes, sir.
Thank you, Sabnis sir. Thank you, Kirpekar sir. Actually, it was Cyan once upon a time known for Millin's prostatectomies, and this was a credit going from Dr. S.D. Bapat to Sabnis sir and to us.
Yeah,
So,
actually, in our time, Bapat sir, if you ask Bapat sir to demonstrate one surgery, he would demonstrate Millin's prostatectomy, and therefore,
I know.
every
So
step,
legacy.
whoever has passed from Cyan Hospital, every step, he will not even like to deviate from one step to other step for Millin's prostatectomy. That was his pet surgery, and we all learned from this, and we are still, after so many years, confident to do Millin's prostatectomy simply because the steps were repeatedly done in the same manner. So that is credit to Dr. Bapat sir.
Thank you, sir. Thank you once again. It was actually important take-home message for many of the residents. And now moving to the next, Dr. Vivek Venkatramani. He is a young dynamic robotic surgeon working in various corporate hospitals in Mumbai. And over and above, he is a mentor for robotic surgery at D.Y. Patil Medical College in Pune with us. And he is going to talk about robotic simple prostatectomy, the benign prostatectomy. So over to Vivek.
Thank you very much to all the West Zone Council, Sable sir, for the kind introduction. So actually, Sabnis sir's talk has really set the stage for the robotic simple prostatectomy. Today, it's kind of a combination of the Millin's and the Freyer's which is done. I'll show you that in the video. So it was first described in 2008 by Sotelo et al. And subsequently, there have been a number of modifications to the technique. And that's what we'll kind of see in our video. So it's an alternative modality for enucleation of very large prostates. I also feel especially more than 100 grams where it can give all the advantages of the open approach with minimizing the complications and the blood loss. So as coming to the evidence, there are no real RCTs comparing robotic simple prostatectomy with any other techniques. It's purely an extension of the traditional open approaches. But studies have shown significant improvements, obviously, in the Qmax and residual volume after a robotic simple prostatectomy. It's a fairly simple procedure to learn for a robotic surgeon, and there are significant benefits versus the open approach, especially the bleeding, which is minimal because of the pneumoperitoneum. The visualization of vessels is so clear, and as Sabnis sir demonstrated so beautifully, we retrigonize the fossa even in a Freyr's prostatectomy in this particular procedure. So there's a very rare need of transfusion in robotic approach. Almost more than 20% was the traditional described for open. Probably it was even higher than that. And even bladder irrigation after a robotic prostatectomy is almost non-existent. There's now minimal incontinence as well, with clear visualization of the apex and the urethral margin. So it's less than 1%. In comparison to the laser enucleations, however, there is a possibility of a longer catheterization time because we do a cystotomy and we have to close the bladder, and the length of stay may be longer as compared to the laser approach because we have an abdominal drain and we are going transabdominally. The advantage as compared to the lasers is that we avoid any prolonged urethral instrumentation. So you're practically eliminating any risk of urethral stricture after a robotic simple prostatectomy. So the approaches are standard, pretty much transperitoneal or extraperitoneal can be performed. And more or less now it's a combination of the Freyr's and the Millens that is done. So position is again a low lithotomy or a supine with a stripped and Renenberg position. And the ports and instruments are more or less the same as a radical prostatectomy. So I'll just go through a case. So as a 75-year-old gentleman, like Birla sir had mentioned, the GP had started on Weltam for 6-7 years, and he actually had a 150-160 gram prostate. Even on DRE, it was really huge. Couldn't get, anywhere near the top of the prostate. And he also now presented with a 2-centimeter bladder calculus. So that was the reason we went for a transvesical approach as well. So just get on with the video. So we've inflated the bladder, and you do a posterior cystotomy without, dropping the bladder. Previously, it was dropped, the Retzia space was dissected, and then you would do an anterior cystotomy. But now you can, just keep it in place and do a posterior cystotomy. Use good stay sutures from the corners of the incision up to the psoas minor tendon on both sides, which allow you to retract the entire incision, and also an incision stay suture through the anterior abdominal wall to retract the anterior leaf of the bladder. And once that is done, you can see that the exposure is really nice, and you can see the adenoma coming into view. You identify all your landmarks. The stone is there seen sitting in the corner above the median lobe, and that's the right ureteric orifice. So the adenoma is fairly far away from that, and there is the orifice of the left side. So subsequently, you're going to mark circumferentially the line of incision. You place a good traction suture in the prostate, which allows you to retract it left, right, up, down, and, move your dissection as you wish. So after the incision, these are the, you go into the plane around the adenoma. And because of the robotic vision, this Freyr's is no more a blind procedure. You can really see exactly what you are dissecting, and you're absolutely able to go in a pretty avascular plane. There are some vessels which do come. So either your plane is wrong or you have reached the, prostatic capsular vessels, which you need to coagulate. So that allows the hemostasis to be pretty good usually. And there's really very rare instance of blood transfusion in these cases. So you proceed along that circumferentially. Left side was what I started with, then move to the right side. And you can see that the glistening white adenoma is on my left hand with the bipolar. And I'm incising with the scissor and dissecting it away. And now we've come to the anterior surface where it's usually the thinnest part of the prostate. And now slowly we make our way towards the apex. And, being very paranoid about the urethra and the apex when we are doing robotic radical prostatectomies, kind of take a similar approach even for these simple prostatectomies. So I spend a lot of time in getting the urethral apex very well dissected so as to not cause the incontinence. So this was one of our earlier cases. So actually I just wanted to bivalve the prostate just to understand where the catheter was going through, but really that's not usually needed. So now the urethra is just coming into view, and you can just separate gently all the tissue away from it and incise the urethral edge, and you can see it pretty clearly, and you get the prostate and the whole adenoma proximal to that, and you'll not go anywhere distal, damaging the urethral sphincter. So these are the final bits of attachments that you would then need to divide of the urethral edge and the adenoma. Sometimes there are small little nodules which remain, so you may need to take them separately. And that's, you can see it's as big as the bladder almost. This was about 160 grams even after we weighed it. And hemostasis is pretty excellent. You can bipolar or monopolar all those small bleeding vessels that may be in and around the prostatic fossa. And then we also will retrigonize the bladder, and this helps in the hemostasis as well as minimizes the bladder neck contracture, as sir was saying. So with the robotic approach, you can see it really, really well and get the whole posterior bladder mucosa down, right down to the urethral margin. And sometimes we even do it 360 degrees if it's possible, continuously all around. In this case, we were able to do it to some degree. So, the raw surface is quite minimal, and you have a very good healing of that area. And so you don't really need to give much traction actually, and no real irrigation is needed after this procedure. And subsequently, you close the cystotomy. It's personal choice, 1 layer, 2 layers. And, that's the end of the procedure. We did put a drain. Drain is usually 2-3 days. Make sure there's no leak. And then we discharge the patient with the catheter, which is then removed, 10 days, a week or 10 days later. So this was the final specimen that we extracted in this case. So a robotic simple prostatectomy is an excellent alternative. It has minimally invasive advantages, as well as avoiding any prolonged urethral instrumentation. There is no upper size limit, as Sabnis sir mentioned. It is a major surgery, but today we can do it with minimal complications. So it's a good alternative to the open approach as well. So thank you, everyone. And I hope that was of some help.
Vivek, it was an excellent video, and I'm sure many of the people must have appreciated this another way, a non-traditional way of going ahead with the benign cases as well. And because this is under clear vision with a 3D vision, though that cannot be transmitted, but we know how clear vision it is on 3D on a console, and being bloodless. So this is a valid approach to go ahead with a very large prostates. It is something what Sabnis sir had shown was with a good magnification and a good vision.
Thank you, sir.
Excellent presentation, Dr. Vivek. Very good, very nice demonstration. And congratulations to you for offering such a nice video.
Thank you, sir.
So we have come to the end of it. So before we stop, if there are any queries from those who are attending, viewers, they can go ahead. That is one. And secondly, if our West Zone members and those who are from other zones do like this idea, please give your feedbacks how we can go ahead. On behalf of West Zone, I really thank everyone, all the speakers, our expert panelists, and all those who have attended this webinar. We will keep continuing this academic activity, and so that our younger generation is ready with their exams, ready with different aspects of the subject. If there are questions, they are welcome.
While we see if there are any more questions, I would like to thank all my panelists for keeping the time, doing very good presentations, and the slides were of a very good quality, and delivering a very clear message for all the junior trainees who would be listening to this talk. And I would also like to give special thanks to Dr. Sabnis sir and Dr. Kirpekar sir for guiding us and for sharing their years of experience and wisdom. Thank you very much, sir.
At the end, we thank the West Zone, the president, the secretary, other council members for giving us opportunity to conduct this first of its the starting first webinar and academic activity. So thank you, everyone.
Thank you very much.
And we will meet on 25th again.
Yes, we meet again.
Correct.
Thank
So
you.
the next,
Thank you.
the part 2 will be 1 week later. And if there are suggestions, there are some aspects of the subject which are not getting covered in these two, like the complications and management of complications and instrumentation for various procedures. That if that gets covered in the subsequent, it's fine. If it is not getting covered, a third part can also be introduced on a popular demand. Thank you.
Excellent. Thank you very much.
Thank you.
Good night.
Thank you. Thank you.
Thank you. Thank you, Subodh. Thank you, everybody.
Good night. Good night, Rajesh. Good night, Ashish.
Good night, Rajesh. Good night, Ashish.
Thank you.
Thank you. Thank you, sir.
Thank you. Thank you, everybody.
Abhijit, thank you for excellent back support.